Okay, so today it's very nice to see all of you again. I think you all have logged in to a lot of webinars, probably heard some of us talk before, but it's very different. It's very different talking to audience and talking to a computer screen. As a presenter, it feels very weird talking to a computer screen and looking at my own face. So I think it's very good that we are doing this. We did this a couple of months back. We wanted to do this last month, but because of the surge in cases, we decided to postpone it to today. There will be another session next week. Edgar and Wanxian will be talking about a different topic. Okay, so today my task is to share some knowledge or some updates that we understand during the last 1.5 years during the pandemic, some lessons that we learned. I'm going to talk mainly about COVID and the heart. I'm going to skip this slide and this slide because Dr. Tan has gone through them. So I'm going to quickly go through a few things. Number one, I'm going to go through the stages of the disease, which I think most of us are familiar with, but I think it's good to have a recap. What are the common cardiac complaints or consequence of COVID patients? Okay, these are COVID infection patients. Then, of course, these are the $2 million questions. Should our patients go for vaccine? I think today is without a doubt that they should go for vaccine. But then I think this is the other $1 million question, right? Is it 100% effective and safe? So I hope I can address some of these things over the next 25-30 minutes. I think it's important to start off by understanding how severe COVID infection is, and this is taken from data from last year, 2020 to March 2021 this year. So the total number of deaths from COVID as recorded by CDC is in excess of all the previous years of influenza flu death. Right? So all the years from 2010 all the way down to 2019, you add up every single influenza flu death in USA, it is less than 1 year of COVID. So it's one of those pandemics that unfortunately we are still having to deal with today. And this is taken from 1st November, total death worldwide 5 million. Total number of confirmed cases, 246 million. And we are still seeing cases every day, and we are unfortunately still seeing deaths every day. This is taken from Singapore's back home, where the latest one that I managed to pull out in October 27. Our numbers used to be very good. It has gone up a fair bit. But I think what we can take heart on is that most of our patients have very mild symptoms, and the number of patients that requires ICU care, critical care, and those who don't make it, fortunately, is a small percentage. But because Singapore is a very small country with limited medical resources, even 0.1-0.2% of the total number of cases which we have, which is more than 90,000 already, is still quite significant, and it can overwhelm our hospital resources. So I think that's why we are still doing what we are today. We're having restrictions and limitations, going out and wearing masks, etc., etc. So these are the reasons why. Okay, let's start off by the simple facts. COVID infection, anyone who catches COVID potentially can go through 3 stages of the infection. The first stage is a very mild stage, which is usually called the flu stage, where you have some URTI symptoms, cough, running nose, and they usually resolve, and 80% of them will recover. All right. A small number of them with underlying lung disease or those who are highly predisposed immune system overreaction will go into COVID pneumonia or COVID lung disease. And then subsequently, when this stage sets in, then you have the hyperinflammation phase, which is where most cardiac complications occur. So borrowing this slide from most of the literature, you'll probably see when someone catches a COVID infection, there will be a viral response. The viral response will go up, and if it goes up and goes hyperactive, then you go into this phase where there's a lot of hyperinflammation. Hopefully, most of us will be in this phase if we catch it and then comes back down to normal, since most of us here, all of us here, sorry, have to be vaccinated, right, before we can come in. So vaccination is supposed to give us that kind of protection, although it is not 100%. So for a patient who has COVID, what are the common things that they can complain about for cardiac symptoms? Well, I guess the most common would be chest pain, and quite a significant number of them will have chest pain. And the causes for chest pain as a cardiologist we have to think about would be acute coronary syndrome. Sometimes they get what we call stress cardiomyopathy, which is Takotsubo cardiomyopathy. Myocarditis is becoming more and more the diagnosis is becoming more and more rampant because we are seeing more and more. And we also have to remember pulmonary embolism. Sometimes we'll also present with chest pain. So besides chest pain, quite a lot of you have asked me, and I think this is also very common, they will also complain of palpitations. And the most common palpitation that they will complain of is the heart rate is going higher. They will kind of tell you, my resting heart rate is now 90 to 100. I just walk up the stairs, my heart rate goes to 120. And that is some form of sinus tachycardia mostly, and it's usually an inappropriate form of sinus tachycardia. They are generally benign. We believe it is immune-mediated and usually resolves spontaneously. But there are patients who present with more PVC, premature ventricular beats, PAC, premature atrial complexes, sometimes paroxysmal atrial tachycardia, which is what I've seen. Unfortunately, atrial fibrillation, which is what I've seen. Fortunately, I have not seen a ventricular arrhythmia, but this has all been reported in literature. So for COVID infection patients, later I'll share with you some cases. These are the arrhythmias or that can cause palpitations. Okay, last but not least, COVID, you cannot go without discussing pneumonia or lung infection. So they will always have some form of breathlessness, right? And when they have breathlessness, this is normal chest x-ray. This is what the bacterial pneumonia look like. Viral pneumonia, less angry looking. Some of the COVID pneumonias can be quite angry looking. So later I'll show you some x-rays. If the patient has got cough, breathlessness, x-ray usually will pick up some changes. Then we're going to think about, is it just pneumonia or pneumonitis, interstitial pneumonitis, or the patient could also concurrently have heart failure, as well as sometimes the heart is so big, you have to entertain the possibility there's pericardial effusion due to pericardial inflammation. So these are the things that we have to think about when we see a COVID patient, usually in ICU, in the isolation ward. Okay, so how does the virus or the infection causes heart complication? Well, this is now very well established and it's quite well studied. The COVID virus itself has got the spike protein. So all our vaccination is to target the spike protein production, right, your mRNA production. And this spike protein is the one that can directly be attached to the cardiac myocytes through the ACE2 receptor, and therefore inciting an inflammatory response. That is one common mechanism that has been well established. The other mechanism that is also well studied would be the indirect damage caused by the induction of the inflammatory response. So your cytokines, interleukins, or lymphocytes, when they react too aggressively to the virus, then you can also get collateral damage, and most of the time it can be within the myocardium or the pericardium. So the most common complications would be damage to the cardiac myocytes, sometimes necrosis, and you end up with what looks like an MI, but actually most of them may have just myocarditis, which will can be from mild to severe, and some form of pericarditis as well because of the associated lining between the myocardium and the pericardium. So a lot of literature has been published over the last 1 year. I think that's the most expedited publication for one condition for our lifetime. This is a very nice table just to summarize all the different conditions that the COVID virus can cause. So arrhythmia, cardioembolic, thromboembolic events, PE for example is very common, or at least very common in the acute ICU setting. Heart failure is not uncommon, especially with underlying myocarditis or cardiomyopathy. And coronary events. So I'm going to also share a case of a patient who have a blood clot causing acute coronary syndrome. Okay, but besides limiting us to watching webinars at home, COVID consequences is actually quite severe, because we used to do elective procedure for patients who may be mildly symptomatic or early symptomatic, and thereby we get them to be treated and they will have a good outcome. Unfortunately, due to overwhelming number of cases where a lot of elective procedure, or elective is in inverted commas, so non-urgent procedures would be delayed. And if you delay non-urgent procedures, including some cardiac procedures, fortunately in Singapore we don't have to do that, but in many parts of Europe and America they have to do that, you will see a different trajectory for the patient. So somebody who has stable coronary artery disease, angina for example, if you have an angioplasty done, you're going to get a good outcome. If you don't do and you wait for them to get an acute coronary event, then their outcome will be very different. If at that point in time you don't have the resources to manage an acute coronary event, then maybe the outcome will be in this untreated form, and that is dismal. That's almost as good as going back 30, 40 years where we don't have angioplasty or any form of treatment for acute coronary event. And this is definitely not just what I say, but it's published in the literature, and this is from a European center. If you look at this table, it is very, very unfortunate, but during the COVID peak in Europe, there is a reduction in all hospitalizations and referrals up to 90% for all patients with a diagnosed acute coronary syndrome. And that, unfortunately, will always predict a not so good prognosis. In terms of coronary angiography and PCI, which is what Dr. Tan and Dr. Stanley does, about 1/3 gets deferred. That means you don't do it immediately or urgently, either due to the worry that the infection will spread to the staff or the lab is not capable to handle an infected case. So there are a lot of delays or so-called medical treatment. So reperfusion is delayed. There was an increase in usage of what we usually do, the thrombolytics, giving streptokinase and RTPA, up to 20-25%. And unfortunately, if you don't have a timely revascularization, the increase in cardiogenic shock and acute heart failure will also increase. And again, they'll be fighting for beds with the COVID patients for ICU. So that's one of the reasons why when the COVID surge comes on, we are very worried because other patients who don't have COVID will not be able to get the care that they would otherwise get in normal so-called peacetime. Okay, so patients ask me, a lot of GPs ask me, I did give a talk in the Parkway CME some months back, and I think it was quite well received, so I'm just going to share some of those things that we had then and update what we have today. Okay, this is the first thing that I always tell my patients and tell them that the older you are, the more likely you will be hospitalized for COVID. I think this is true regardless where you are and which part of the world you are, all right? Whether you have comorbidities or not is an additional confounder, but just by age alone, the older you are, the more likely you will need to be hospitalized for COVID. But the other piece of information which is very interesting when I was preparing this talk is that for the young, you may see that there are people who are infected with COVID in the dark blue bar, but all-cause death excluding COVID is still higher, right? From 0 to 19 years old, 20 to 49 years old, even 50 to 69 years old, all-cause death from non-COVID conditions, be it a stroke, an AMI, someone who comes in with urosepsis, is still higher than COVID deaths in this age group. But once you look at above 70 years old as a cohort pool, then the number of COVID deaths actually is a lot higher than deaths from non-COVID causes. So I think this is the group that I think is the most vulnerable, the group that our parents unfortunately are in right now in this age category, and the ones that we really want to look out for, right? I'm not saying that you don't need to worry about the younger people, but as a general epidemiological statistics, the younger people succumbing to COVID is a lot lower than the older folks. So I think it was useful that the Singapore Heart Foundation also had something on their website, FAQ, safety of vaccine. So simple things when patients ask us, we say, it's actually safe. You don't believe, you can check this website. The Singapore Heart Foundation website actually says that, heart patient with low heart function, less than 50%, either cardiomyopathy or post-AMI, they can go for vaccination. They should go for vaccination to protect themselves. They're taking many, many medications, including a blood thinner. They can go for vaccination, and they must and should go for vaccination to protect themselves. Right? So these are all well established, at least definitely in our local setting. Okay, just a little detour from before we talk more about the vaccine. I think this is just a refresher for myself. There are currently 4 different types of vaccine available in the world for COVID vaccination. We are very familiar with the RNA because we have both brands here. We don't use any of this because we don't import AstraZeneca and Janssen. We do have Sinovac and Sinopharm in Singapore, and as I was preparing this slide some time back, this was supposed to be coming Novavax, but we still don't know whether it's going to happen. Of all these different vaccine groups, the only one that's novel is the RNA because there's no other vaccine in the market that is similar technology. Viral vector, I think Ebola is an example. A lot of this whole virus inactivated form from whooping cough, rabies, hepatitis A, even HPV, they are all similar in technology. So this is not really new, right? And then for protein subunit, then we are most familiar with hepatitis B, which all of us have been vaccinated for. So these are all the vaccines that currently are available. In Singapore, we only have the mRNA and the whole virus as of now. So this was what MOH and circulated to all of us and to tell our patients. I think it's useful to use infographics, right? Let the patient say that, hey, green tick, green tick, green tick, green tick means all okay, right? Hypertension, high blood pressure, cholesterol, diabetes, all should go for suitable for vaccination. Initially, these are the 3 crosses, right? Those who have anaphylaxis. Anaphylaxis is still relatively contraindicated. Immune system deficiency problem or those who are immunosuppression, I think case by case basis, your doctor will advise you, but right now it's not contraindicated. Very low platelet count if there's a diagnosis and if the patient is stable, it's also not a very strong so-called contraindication. So having said that, how does our vaccination number looks like as of 7th of November? I think this is as best as we can get. This is across all age group, right? From the young, 12 to 19, to the 80 years old. Those who have completed is in gray. I think we are not too bad. On average, more than 80-something% for all age group. There are a lot who have received 1 dose, and for some reasons, actually for good reasons, they have not taken their 2nd dose because quite a number of them may have got an adverse event that does not allow them to take the 2nd dose. There will always be this number that are unvaccinated, okay? And I don't think whatever we do, we can make this number 0. I think it's also not practical to make this number 0. Okay, but what I think is interesting here is that the above 80-year-old group is a higher percentage. More than 10% of the above 80-year-old group have chosen not to be vaccinated, or their kids have chosen not to vaccinate their parents. So I think this is all by choice. So this is one typical myth, which I also extracted out from the Singapore Heart Foundation website. My parents are 90 years old. They're advised not to take the vaccine. They don't want to take the vaccine because they say they don't need to go out, therefore they are not at risk. Well, unfortunately, in the Asian context, that is not 100% true because even if you don't go out, you receive guests. And if you have different groups of people coming to visit you every weekend, you will be subjected to an unknown. And the unknown here is that somebody who is vaccinated can carry the virus, asymptomatic, and pass it to you. And because you are in the elder age group, if you remember my first slide, the risk of you falling sick is very high, and the risk of you going to ICU or hospitalization is even higher. So I think on that note, if we really want to protect our seniors, it is still advisable to go for vaccination, right? Even though they are old. But of course, if your grandparents or the elderly says, I don't want, I'm happy, if something happens, I just go. I think that's again by choice. We cannot force everyone to take a vaccine, okay? But if anybody asks you, what is the data that vaccine works? Well, I think this is a very nice piece of information from the UK Public Health to show you that if you go for vaccination, you reduce your risk to another age group risk. For example, if you are a fully vaccinated 80 years old, okay, your mortality after vaccination, right, is the same as an unvaccinated 50 years old, which is actually very, very good because if you are 80 years old and you have been vaccinated, and if you know that the risk of you dying from COVID is the same as a 50 years old, means you have done quite a lot of protection for yourself. And similarly, the 50 years old who is vaccinated will have the same risk as a 35 years old. Okay, so this is a very nice chart if you need to show your patients, look, if you're vaccinated, you'll be here. If you're here, you're the same as this guy. I think this kind of infographics is very useful for you to advise your patients what is the benefit, right? Rather than telling them, oh, 0.1% will not die from, from ICU care or death. Sometimes something like that will make them wake up and say, I think if I'm 80 years old and now I have the same risk as 50 years old, quite good, right? As long as I don't get any complications from the vaccine, right? Okay, with that, I will just share 2 cases. Both are COVID positive cases. This is from one of my friends from a restructured hospital. 40-year-old male, I think this is a foreign worker, no medical history, came to hospital for chest pain and breathlessness, fever 38 degrees. A&E, he was actually a bit disoriented. SpO2 was not bad, 96%, not too tachycardic, but he was on a 100% non-rebreather mask. So 100% non-rebreather mask, young guy, SpO2 still just hit 95. Usually it's not a good sign. And then obviously his COVID PCR was positive. So this was his chest x-ray, nothing too impressive, right? It may be a little bit of a patch here, starting to have some pneumonia infiltrates on the one side. But I think the ECG is quite impressive. The ECG shows very clear-cut ST elevation, 2-3 AVF, with ST depression in 1 and AVL, and then ST depressions in V1, V2, V3. So this is a typical right coronary artery infarct. And he went for coronary angioplasty. Fortunately, in Singapore, this can be done. Coronary angioplasty done. There's a clot. After clot being retrieved, I think my colleague told me, because we don't see the acute COVID AMI in private hospital, I think my colleague told me that they didn't have to stent. After they aspirated, they just balloon. And actually, this is post angioplasty without any stent, because this patient didn't have plaque. So what this patient had was a lot of clots. And the clots went down to the right coronary artery and caused an acute myocardial infarction. So this is one of the atypical presentations for AMI during this COVID pandemic that we only saw in the last 1.5 years. Before that, every single RCA occlusion, after you put in the aspiration catheter to suck out the clots, Dr. Tan will tell you, you will almost always see some plaque there. All right? But in COVID era, some of these young people don't have plaques at all. It's just a pretty smooth vessel. Maybe it was inflamed. Therefore, it induces a clot formation. All right, so this is one case. This is another case that I saw recently in Gleneagles. 81-year-old male. He's a hawker. He has no medical history. He was vaccinated in July. He was transferred from the community care facility to Gleneagles because government hospital was full. So Parkway Hospital gave up 400 beds for community care facility to be transferred if they need medical attention. So this gentleman, after transfer, he became progressively dyspneic. He was getting more and more breathless, sats was getting low. So we sent him to ICU. Then I was called to see him because he had new onset atrial fibrillation with ECG showing again ST elevation. All right. So the troponin T was 29.1 when they called me, and then the subsequent one 8 hours later was 36. So this troponin elevation is usually not typical for an acute heart attack, because if it's an acute heart attack, after a couple of hours, it will really go up to the hundreds or even the thousands, okay? And more importantly, the cardiac CK MB, which is a subset of the full CK, is only less than 5, which is within normal range. So again, this is not likely to be an acute coronary syndrome. So this was the ECG from the patient that I saw in Gleneagles. First, you can appreciate that this is in sinus rhythm. You can see the P wave quite clearly, regular. But ST up, 1, 2, 3, AVF, V2, V3, V4, V5, V6, everywhere, virtually everywhere. So somebody with ST up like that, very nice saddle shape ST, textbook teaching, this is pericarditis. All right, so this 81-year-old patient had acute pericarditis. This was in the morning. And then later in the afternoon, he went to AF. Right? So it's not uncommon. Whenever there's pericardial irritation, they will also cause a little bit of irritation either in the atrium or the ventricle, but commonly in the atrium. And some of them can again get atrial fibrillation. But of course, by age criteria, he's 80 years old, he can get atrial fibrillation just by age criteria. Right? So 10 to 15% of above 80 years old can get AF. But when they are sick, when they have infection, then this is more common. So this patient actually has AF with pericarditis. So again, managed as conservatively. The D dimer was very high. So this was his X-ray. So he came in like that. Then he started to have a little bit more patch. So the last chest X-ray, which was taken just about a week ago, he's out of the COVID isolation because his CT level is really more than 45, which means he's no longer infective. But his lungs looks like it's going to remain like that, which I think is not so good for him, given that his lungs used to be like that. I think on hindsight, when you ask him, he used to be a smoker. He's probably still a smoker. But I don't think he'll be able to smoke anymore because I think the lung function probably will not recover totally for this patient. So with the D dimer so high and the echo showing some elevated pulmonary pressure, we elected to treat him with anticoagulation for presumptive PE because he had all the other supporting features of PE. The only thing we didn't do is we didn't send him for a CT pulmonary angiogram. But because the medical intensive team plus myself have already decided that we should anticoagulate these people, especially with a high D dimer. So whether you do a CT or not is really not going to change the management plan. So sometimes in COVID, in the pandemic era, we have to make certain medical decisions not based on an investigation finding or confirmation, but we base it on the best set of evidence that we have at that point in time when we see the patient. Okay. During the last 1 year, guidelines sprang up all over the place. There's actually a guideline for diagnosis and management of COVID disease during the pandemic. If you're interested, it's on the ESC website. Okay, lastly, I will just quickly go through vaccine safety and efficacy. Okay, I think first thing first is we cannot expect any vaccine to be 100%. So I think no vaccine in this world is 100% effective, all right? Our influenza flu vaccine that we give to our patients every year when they go for their winter holiday is at best 50% effective. The rest, chickenpox vaccine that we give to kids is at best 90%, 92% effective. Then measles MMR vaccine at close to 97%. Even polio, after many doses, you hit about 99%. So with the COVID vaccine hitting 90% and for the AstraZeneca one about 70%, it is a good vaccine, good enough in contemporary era to say that it's actually a decent vaccine. It's not something that is 50-50 chance. And how useful are these vaccines? Well, I think as we see more and more mutation, the usefulness of the initial vaccine will become less and less, right? Because the initial original virus, the efficacy is here, 95% for the 2 mRNA, and for the J&J and AstraZeneca is in the high 70%. But once you start to have mutation, then you will start to see the percentage drop. So it becomes less efficacious. The people in the labs are still trying to figure out whether giving additional booster is going to make it more efficacious. The answer is we don't know. For all of us, including myself, who have taken the booster, we are all part of this worldwide randomized control trial. The results will be released probably when we are not around. So the next generation will probably know whether we did the right or the wrong thing to take 2 and 3 shots. Okay, but in any case, today the recommendation is to take a booster in order to try and deal with the lower efficacy of the original vaccine. So again, we have very nice infographics. COVID-19 vaccine is effective in the vast majority who are vaccinated. This is true for the initial original virus. And again, we have very nice graph to show you that if you are fully vaccinated, you have a 0.5 per 100,000 population chance of going to ICU. If you're not vaccinated, it is almost 5 times higher. So it's 5 times higher risk to get into ICU. If you are vaccinated, the risk of you dying is 0.1 per 100,000. And if you're not vaccinated for all age group, it is 9 times higher. So these are the 2 figures that maybe is useful for you to share with your patient if they ask you, if I don't vaccinate, what does it mean? If I vaccinate, what does it mean? So 5 times higher risk of going to ICU, 9 times higher risk for dying. All right, it's the same as I tell an AF patient, if you don't take warfarin or anticoagulation, you have a 5 times higher risk of getting a stroke. Okay. Of course, it doesn't mean you will get a stroke, but if you are predisposed to getting a stroke, you have a 5 times higher risk than your contemporary for the same age. Okay, and lastly, is it safe? Well, I think initial data, and this is another infographic which I pulled out from MOH, it is safe. There are some side effects that we are now starting to see a lot more. So I'm going to share with you two cases of my patient. The first one is a 50-year-old male, no medical history. He went for COVID vaccine with Pfizer on the 9th of April. And then 4 days later, he had palpitation and he was feeling irregular heartbeat. So he went to see his GP downstairs. The GP did an ECG and said, you better go to A&E now. So his ECG was like that. He had new onset atrial fibrillation. Okay, so here, is it a coincidence or is it just by chance he had it just after the vaccine? Okay, nobody will know, right? This is postulate, right? But the timing is quite close to the first dose, right? So this patient actually had atrial fibrillation and went to A&E at NUH. So at the A&E, he spontaneously reverted back to sinus rhythm and he was well. So he was sent home. And then he was started on Concor. no anticoagulation, I think it's not wrong again because this new onset AF happened in less than 24 hours. So whoever saw him and said, okay, you don't need anticoagulation, you are now back to sinus rhythm, since it's such a short time, should be safe. So I send you home. Unfortunately, 3 days later, he was admitted again to the same hospital for sudden onset expressive aphasia. So expressive aphasia, as you all know, means he can't talk and express himself properly. He's able to understand and obey commands, but you ask him, what is this, what is that, where are you now? He can't verbalize it. So this is a very typical area of sometimes in the cardiac embolic stroke in the anterior circulation, as well as an MCA. So the CT head was done and it's normal, and they said, okay, since your symptoms resolved, which resolved within 24 hours, he was diagnosed with transient ischemic attack and then he was sent home. So why did he come to see me? He came to see me because he wanted to ask 2 questions. Number 1, did he have a stroke? And number 2, can he go for his second jab? Okay, so that's the 2 questions he came to see me for, which was very tough, right? So I said, based on what I can see in NEHR, they say you have TIA, so you didn't have a stroke. So I said, if you want to know whether you have a stroke, then we do MRI. So the MRI actually showed infarct. Okay, so it's not a TIA. It is an infarct. It could be because of the atrial fibrillation. It could be because of hypercoagulable state after a vaccine, we don't know. But clearly he has an infarct. And because you have an infarct with atrial fibrillation, by all guidelines, you will have to take lifelong anticoagulation. Right? So one unfortunate consequence of this situation is that he has to take lifelong, I think he's now on apixaban because it was started by NUH, so I kept him on apixaban, lifelong apixaban. That part we resolved. So he had a stroke. He was well. He was able to talk back to normal as per normal. He could even exercise. But because he had a stroke, he has to take lifelong anticoagulation. The second question he asked me, so should he go for his second jab? So I asked him, what did the doctors in NUH say? They say it's not related. They say if they say it's not related, then in theory, you should go for your second jab. Because if you are halfway, then you are half vaccinated. You are neither here nor there. You can't even come out to eat with your wife, because you're not vaccinated. So he wanted to actually get the second vaccine. Then he asked me, is it safe to do so? I put him on an antiarrhythmic, and I covered him throughout the whole period of time before and after the vaccination. 2 weeks after the vaccination, he came back to see me. I repeated Holter and I repeated treadmill. He had no more atrial fibrillation episodes. I took him off the antiarrhythmic. He's still well today with no AF. He has not felt any more palpitations ever since that day, but he still has to take his apixaban. And so I leave it to you all to think whether at the end of the day, should we report this? Well, the answer is most of us try to report everything, but when we report to HSA and a lot of things comes back to us as not related. Somewhere along the line, we will just lose a little bit of confidence. But I think this should be reported. Okay, so if you look at the HSA website, there are serious adverse event reported. Numbers are very small. Okay, so this is probably adjudicated. 581 out of this 8 million number of doses given. So this is taken from HSA website. Okay, someone was asking me what are the common symptoms do you see after vaccination? Do you see people coming to you with palpitation? The answer is it's not uncommon. 3.2% of people actually have palpitation. Up to 5% of people will have some chest discomfort, chest tightness, non-specific. And about 5 to 6% actually have breathlessness, right? Of all those that I have seen and what my team has seen, a majority are benign. A lot of them, I diagnosed them after the series of tests. I excluded myocarditis, pericarditis, echo is normal. I started them on some PPIs, and within a week, all of them respond to PPI. So maybe a lot of them having chest discomfort and dyspnea is due to hyperacidity. Again, it's something that some of my gastro colleagues also observe after vaccination. So maybe something useful for you all to take home. If you see someone coming to you after vaccination having the same symptoms and your ECG is fine, you can run your cardiac markers. If they're okay, you don't need to urgently send them to A&E or cardiology. You can give them a short course of PPI and see whether they respond. Okay. For the palpitation, majority are inappropriate sinus tachycardia. So if you have propranolol, you can give them propranolol as long as they have no asthma. If they don't want medication, then you just ask them to wait it out because most of them will usually be spontaneously self-resolving. Okay, the next case is a little bit more unfortunate. This is a 45-year-old male, no medical history, vaccinated 2 doses in February, went for booster 17 September, Pfizer, so it's Pfizer. Complaint of sudden onset chest pain on the 21st of October, more than 1 month after the booster, with radiation to jaw and dead sneer, right? So he saw his GP, the ECG, and the ECG was not good, so he was referred to A&E. So this is his ECG when he came to A&E. You can see again ST elevation 2, 3 AVF. But what's interesting here is that V5 and V6 is also up. V1, V2, V3, V4 don't have. And there's no reciprocal changes in 1 and AVL. And what's also interesting is that 1 and AVL, the ST, well, if you want to say it's a bit elevated, I guess nobody can really fault you, but it doesn't really look very classic of acute pericarditis, right? So with this, with the symptom, chest pain, radiation to the jaw, and breathless, ST up in this territory, inferior, lateral, I think we have to do our due diligence. I saw him in A&E, did a quick bedside echo, saw a little bit of hypokinesia in the inferior wall, but not a great deal. Maybe it's very early, so I brought him to the cath lab in Glen Eagles, and normal coronaries, totally normal. Right coronary artery, totally normal, pristine. Circumflex artery, totally normal, pristine. So these are the 2 arteries that will cause an inferior lateral kind of infarct usually, which is totally pristine. So it's not AMI. So what can this be? Well, as we unfold the story, ECG, I already showed you, coronary angiogram, I already showed you. This is the enzymes. The enzymes was very high. His enzyme troponin T was 1033 on admission, went up to 1133, and then subsequently came down. CKMB was more than 10 times normal, right? Normal is less than 5, this is 66, all the way up to 66 and came down subsequently. CRP is not up at all. And ESR is just borderline. Most of you know ESR 15, 10, 15 is quite normal. 21 is not exceedingly high, right? Some people with low chronic inflammation, rheumatoid arthritis can always get 20-something. So I told him I think he had myocarditis with pericarditis. And I said, okay, let's not think, let's just confirm it because I reported this case to HSA. And they asked whether I did a cardiac MRI. So I said, okay, we'll do a cardiac MRI. The cardiac MRI actually shows this whole area of transmural lateral wall as well as inferior wall scarring. So this is myocarditis. And is it related to a vaccine? I don't know. I will let you all know when HSA let me know. So I really informed them. Maybe it is, maybe it's not, but there's nothing else in between this 1 month that this patient did to get this. This is my second patient. I have another patient who also had the second shot and 1 month later had the same kind of a presentation. So if you see somebody coming to you with chest pain, right? Nowadays, I will always ask them, when do you take your vaccine and when was your last booster? I think it's a very useful question because if you don't ask, you'll forget. Okay, the other patient, I didn't ask. I forgot to ask. When I asked him in October, he told me it was just 1 month before he came to A&E. So I said, okay, then let's do a cardiac MRI. And in October, when he came in August, 2 months later, his MRI is still abnormal. Right? So I think we should not belittle myocarditis. It can be something that is there but we don't recognize it. It can be benign in the sense that EF is not affected. You can recover from it, but surely it is an adverse event. Okay, and I think in all the literature you can find how to manage myocarditis. Nobody knows it perfectly very well. The Israeli has a lot more experience, and they find that in their vaccination population, the incidence is not that high. It's about 2 to 3%. Across the board, all right? So it is something that you probably will want to, 2.13 cases per 100,000, so it's not 2 to 3%, I take that back. So it's a very low percentage, but it's still something that you need to be aware of. Okay, so lastly, I think this is something that made news not too long ago, our 16-year-old boy who had myocarditis. The UK statement on vaccination in children, this was in July. I didn't have time to update it. But essentially, I think in UK, they are giving vaccine to kids above 12 years old if they fulfill certain criteria, not across the whole board, not like in Singapore. In Singapore, it's everyone. In fact, with all the restrictions setting in, if you don't get vaccinated, it's very difficult for your teenager kid to do a lot of things. Just to remind everybody, there is a vaccine injury compensation. There is somewhere that you can refer your patient to if they really get a vaccine-associated side effect that they want compensation for. And I believe we will see more, both yourself and myself, because Now we know that if you are unvaccinated, you cannot do a lot of things. Starting from next month, if you are not vaccinated, you end up with COVID, you have to pay the full bill yourself. Okay, and that probably is going to be one very, very big push factor. Okay, so with that, I just want to quickly summarize. COVID-19 is not going to go away. It's going to be here to stay. We will see them still this next year. The cardiac complications are common with COVID infection. Our index of suspicion must be high for somebody who has vaccination and then complain of some cardiac symptoms. But I think overall, we still, as a general healthcare group, we should still confer vaccination is the way to go because the protection is more than the risk. Having said that, the risk, we just need to be more vigilant to pick them up. All right, so with that, thank you very much.